think we should get started. So, welcome everyone. My name is Holger Schünemann. I'm one of the co-investigators, co-principal investigators on the CAN-PCC guidelines that are the topic of our presentation today. Co-chair the working group or the guideline development group, and it's my very great pleasure to introduce our three panelists today that will speak to the guidelines on pharmacological and non-pharmacological interventions for people with CAN-PCC. So I start by introducing Stacey Alexander, who is an educator and a member of the Long COVID Canada admin team. She's a person with lived PCC experience, and as most of you on this webinar will know, all of our guideline teams, we pay great attention to that. All of our guideline teams have people with lived PCC experience as full members, and we've been relying and counting on them in a very important way. The next person who I would like to introduce is Dr. Kieran Quinn. Kieran, I've come to appreciate working together on the guideline development group that is some sort of oversight committee for the individual teams. Kieran is a clinician scientist at Sinai Health and an assistant professor in the Department of Medicine at the University of Toronto. And he co-leads Canada's National Research Network on PCC. So the long.
Sit where I want to be. Ouch.
And last but not least, Grigoris Leontiadis, also a colleague who I've known for a very long time. He's a professor at the Department of Medicine at McMaster University and a member of the Great Working Group, as well as the director of Cochrane Canada. That was one of our institutions, or one of the institutions that applied for the support to develop these guidelines, these set of guidelines. Yeah, so welcome to the three of you, and of course, as I always say, you can always add to what I just said here, and introduce yourself better. But I'm really pleased and very happy that the three of them are here as representatives of the guideline team that made the recommendations that we will be discussing today. And before we move on, of course, a land acknowledgement. The work of CAN-PCC has taken place in Canada, the traditional, ancestral, and unceded territory of many Indigenous nations. We honor the rich cultural and traditional practices, languages, and histories of Indigenous communities across Turtle Island. We pay our respect to the First Nations, Inuit, and Métis people of this place who have stewarded this land for millennia. And this is also, of course, extremely important to us. We will ask you to please send questions through the Q&A system. The slides are presented in both official languages. Presentations are delivered in English with French subtitles that you should all be able to see at the bottom of the screen. And the recordings and slides will be posted on canpcc.ca, which is our website for the guidelines and our recommendations, as well as any supplementary information that we make available to all of you. And with that, I will hand it over to Kieran.
Thank you, Holger.
Grigoris.
Yeah, well, welcome everyone. It's really my pleasure to be here, and I am so honored to have worked with Stacey and Grigoris, along with Holger and actually the entire CAN-PCC team. So we're going to walk you through our particular work and the recommendations we make on pharmacologic and non-pharmacologic therapies for the treatment of adults and with post-COVID condition. Next slide, please. The disclosures, so Grigoris and Stacey have no conflicts. Prior to joining CAN-PCC, I had owned equities in manufacturers of COVID-19 antivirals, but divested those immediately upon being invited to join the team to mitigate any risk of conflicts of interest. Next slide, please. So the three objectives really for today's talk, and we're going to try to get through this as quickly as possible so we have time for questions at the end. The first objective is really to describe the pharmacologic and non-pharmacologic options that we recommend based on our detailed and comprehensive review. The second objective is to share how these guidelines can be incorporated into clinical practice, which is a really important step that goes beyond just making recommendations. And the third objective is really trying to increase awareness of the guidelines such that practitioners and patients and others with lived experience can use them as a valuable resource. Next slide, please. I'm going to really work through these quickly, but these give you the background about the importance and the context of post-COVID condition. And we have to remember that this is a brand new condition. Prior to 2020, on the onset of the pandemic, we didn't have a condition known as post-COVID condition. And we are continuing to learn about it in real time. Next slide, please. The definition is variable across different jurisdictions, but the working definition that we use aligns with the World Health Organization's clinical consensus definition. And post-COVID condition is a set of persistent symptoms that occur within 3 months of your acute COVID infection, and the duration of those symptoms lasts at least 2 months beyond the infection. And it's important to note that those symptoms can vary. They can be a whole host of more than 200 that have been identified. And no individual has necessarily a common set of symptoms. Furthermore, these symptoms wax and wane, and so it really makes it a series of peaks and valleys for people living with post-COVID condition. And a lot of people are negatively affected in their quality of life and their daily activities. It's really difficult to get a sense of true prevalence or how many people across the world have or are living with post-COVID condition. The current estimates are approaching 500 million people. And so it is a major issue that our world and Canadians face. Next slide, please. This is just a reminder of that definition that CAN-PCC specifically adopted the World Health Organization's definition. It's stated there again for your reference, and these slides will be circulated after the webinar. Next slide, please. And this is, again, just another reiteration of how many people around the world are living with PCC, and that was iterated on the previous slide. Next slide, please. I wanted to focus now just on the impact in Canada, since this is where we live, and our citizens are our responsibility as healthcare providers, and we hope to help them. So at present, the estimates are that almost 1 in 9, or 1 in 9 adults, that's about 3.5 million adults in Canada, have experienced these persistent symptoms after a COVID-19 infection. And these impacts have resulted in more than 500,000 adults missing days of school or work, depending on what stage of life they're in. So the impacts stand not only from a health perspective, but also in our society and in our economic impacts are wide-reaching and broad. Next slide, please. As I mentioned, there are over 200 symptoms. The most common ones that I see as a clinician and that have been identified and reported in the literature include fatigue, and that is generalized fatigue, but also very specific and troubling types of fatigue like post-exertional malaise or post-exertional symptom exacerbation, in addition to chronic pain, chronic shortness of breath, brain fog or impairments in thinking and memory and cognition, and sleep disruptions. Next slide, please. I'm going to turn it over now to Stacey, who's going to talk about, as the true subject matter expert, and one of our patient partners with lived experience. Stacey?
Hi, everyone. My name is Stacey Alexander, and I'm a person with lived experience residing in Newfoundland and Labrador. I respectfully acknowledge that the province of Newfoundland and Labrador is the ancestral homelands of many diverse populations of Indigenous people who have contributed to 9,000 years of history, including the Beothuk on the island of Newfoundland. Today, this province is home to diverse populations of Indigenous people. I also acknowledge and respect the diverse histories and cultures of the Innu and the Inuit, and I also self-identify as a member of the Mi'kmaq Indigenous people here in Newfoundland and Labrador. So I'm just going to start with a quote here from Jennifer. Jennifer is in another guideline team. Her quote is, "This is not going away, and with me being on the wait list for the medical clinic for over 270 days, that means that there's a need still." So that is the experience of many people, and especially in some of the Atlantic provinces, we don't have and have never had long COVID clinics. We rely on working with our general practitioners and being referred to specialists, et cetera. I don't know if you want to change the slide there. Perfect. Thank you. And there's a quote from Kimberly, a couple. She says, "As a person with post-COVID-19 condition, I would like to see clinicians consider these guidelines in their practice while having sensitivity when patients are expressing those concerns. The public use of the guidelines to best inform and empower themselves in their health decisions." So one of the things that I got to work with Guideline Team 3 was a good practice statement specifically that addresses the um, acknowledgement of healthcare professionals actively listening to their patient's concerns and making sure that the patient feels validated in troubleshooting those symptoms with their healthcare practitioner. So I'll start with a little background about myself, I guess. I became ill with COVID in the early days. So in 2020, I was acutely sick on and off for about 2 to 3 months. And basically, yeah, January to mid-March. And no testing was available to confirm that it was COVID at the time. But after reading many studies that released out of China, my husband and I were putting two and two together, but still refused testing. Over the course of 3 to 4 months, I didn't really notice a decline in my physical abilities. I was still able to snowshoe, snowboard. I was going for walks almost daily, which I usually didn't have time to do as an educator because of all the extracurriculars after school and things like that. But I was making time to do that. But I noticed over time, my symptoms kind of creeped up on me. I was waking up every single night drenched in sweat with no explanation. And I think it was mid-April that I started with a insistent burning in my inner ear. And upon investigation, we couldn't see anything physical and didn't respond to treatment. And basically, fast forward a couple of months into the summer, I was trying to get back into my regular routine of running, etc. And it just felt like I was gasping for oxygen. I just wasn't getting it, even though my breathing felt normal. It didn't feel like I was receiving what I needed to actually exercise. And I tried after all that, I kind of took a little bit of a break, but I was still not into my regular routine because schools weren't open yet. So it had been March since I was in person with my students. And I noticed when I went back to school, that's when most of my symptoms started really coming to the surface, things that I didn't notice before. I was developing neuropathy. I was bruising after exercise or nothing. We didn't really know what was causing it. Sleep disturbances. I was waking up every 3 hours, like in fight or flight. And I think over that span of time, I had about 200 plus symptoms because there were some checklists that I was going through. Now, they never all occurred at the same time, which made it difficult to kind of troubleshoot what might have been going on. But I was taking I was taking research articles to my doctor on a regular basis. And I was still privileged enough to have access to the Memorial University Library because I just finished my master's in December 2019 before everything occurred. So around February 2021, so I didn't make it through the full school year in my regular duties. I had to take leave from my phys ed portions of the job. So I was 50% phys ed and 50% in the library, and I was able to do some of my library duties because it wasn't as much physical involvement. And I could, wear my N95 and ask everyone to wear their masks when they came in the library so I wasn't exposed, etc. But after that time, I had banked a deferred year salary. So I was privileged enough at that point to make a decision that in September I was going to take the year off work. So I took the year off work, and I realized that not everyone has this privilege, but I use this time to read about my condition and to keep up with current studies because things are being released and still being released on the regular. We get new information all the time, and that's one of the things that I think the guidelines we've struggled with is that what's new 1 week is not new in 2 weeks. So it felt like a full-time job even though I was off work. And at that point, I realized that my doctor or any physician who's practicing and in clinic, like, how do they have enough time to read and learn about these new conditions when it felt like a full-time job to me? So that's why I thought that it was very important to become involved in these guidelines. And it's the main reason why I wanted to become part of a guideline team. These guidelines are so important to people with lived experience, so they don't have to jump through the hoops that many of us have jumped through in the past in trying to figure out what worked best for us and for our personal treatments, because it's such a heterogeneous condition. What works for someone may not work for someone else. So having these guidelines is very important. And it also helps the healthcare practitioners that want to see the patients and want to help as many people as possible, and having these guidelines there to help guide them helps with that process. So I realize that not everyone approaches their journey with long COVID or post-COVID condition the same way, and not everyone was privileged enough to have a year off work. Not everyone's privileged enough to have disability benefits with their employer. So I really think that this is important, and for these guidelines to be created from an equitable standpoint. So part of my involvement was with the Equity Oversight Committee as well as Guideline Team 3 for pharmacological and non-pharmacological interventions. Yeah, and Ashley, and Heather, who are hosting this webinar, I've had the opportunity to work with them with the knowledge mobilization team as well, to read over some of the plain language reading statements that go along with the guidelines to make sure that they're understood from a wider perspective. Yeah, so that's where I am on my journey with long COVID and post-COVID condition. But I'm lucky enough that I'm able to take part. And when I came back to work in 2022, I was able to get a work from home accommodation. So my employer was able to work something out with me so that I can pace myself. I'm able to, do work within my energy envelope. And I think that's really important. And I know we're going to talk about that in a little bit. So I'll hand it off to Grigoris now. Thank you.
Thank you. Thank you, Stacey. And we're very fortunate, very lucky to have you on our team. So I am Grigoris Leontiadis. I had the privilege to be the methodology co-chair together with Kieran, who was the content clinical co-chair. I was so fortunate to work with Holger and the rest of the team on these guidelines. So just a few words quickly about the methods introduction, and then I'll hand over to Kieran for the actual recommendations. So we know that, as Stacey explained, we still don't know as much as we need to know. There are still gaps, and new studies come all the time, and they try to gradually fill in the gaps. But the thing is, we cannot wait forever for all the gaps to be filled before we start doing providing some recommendation for individuals. That's why we started this guideline. So next slide, please. And there are studies that showed that in Canada, only 1 out of 8 adults who sought support for their symptoms felt that they received appropriate care. So there is room for improvement. Next slide, please. We work together. So the CAN-PCC project is a project to improve care for post-COVID-19 condition. And this was conducted by the Michael de Groot Cochrane Canada Centre and the McMaster Grade Centre, and was funded by the Public Health Agency of Canada to develop, mobilize, and evaluate evidence-based recommendation on PCC. Next slide. So who are we? It's a huge team, and there's no way I can go through these 150 people who got involved and worked really hard. Health professionals, persons with lived experience like Stacey, policymakers, health economists, researchers, and people had expertise in PCC or related conditions, in guideline development, on evidence synthesis, on knowledge mobilization, and impact evaluation. Next slide. And we had 6 guideline teams that we will show you in a couple of slides. And each guideline team focused on a specific topic area that included a diverse range of experts, as I explained before. So next slide, please. And here you see the pictures of the people with lived experience, and Stacey is there. And we're really, really grateful. The guideline would not have been able to be what it became without them. So we had at least 1 or 2 patients, people with lived experience, participating in each guideline team, and they provided their own perspective on, and they helped us develop the recommendation. Next. So the principles and the process of this project is that the presentation was balanced. There were key groups of collaborators. There was a transparent approach, evidence-based systematic approach. There was independent management of conflicts of interest, and there was standardized training through InGuide for this process. Next. And very briefly, the guideline process is that we selected the topics and questions through a very rigorous process involving public involvement. We drafted the recommendation in draft form initially. We consulted the public again and received feedback, took the feedback into consideration, and then we're at the stage where we finally released the recommendation. Next, please. And here you see the 6 guidelines that I mentioned before. So the first one is about prevention. For example, should we use masks or COVID-19 vaccines to prevent long COVID, PCC? The other one is about testing, identification, and diagnosis. For example, should we use D-dimers or should we use C-reactive protein to test for PCC? The third one is the one we are now, the pharmacological and non-pharmacological clinical interventions, and you will see the recommendation in a moment. The fourth one is about neurological and psychiatric topics, for example, about cognitive behavioral therapy or SSRIs. The next one is about pediatrics. For example, should we use adapted school programs or not? And the last one is about healthcare services, systems, and social support. For example, dealt with topics like remote in-person appointments or care navigators. Next, please. And all the recommendations we're going to talk about today, the ones that Kieran will present in a moment, will be what we call conditional recommendations. There will not be any strong recommendations. They're all conditional, which are issued when the balance between benefits and harms is small. There is low quality of evidence or very low quality of evidence, and the values and preference of patients vary. And what does that mean? It means that most people would want to follow that recommendation, most people with who are suffering from that condition, but many would not everybody. And for the health care professional, this means that they should understand that different options will be appropriate for different people and should support you in making decisions that align with your values and preferences. So they have to spend some time talking to you to assess your values and preferences. Next. And here I'll pass on to Kieran for the meat of this webinar. Thank you.
Thank you, Grigoris, and thank you, Stacey. So I'm going to give you a few recommendations here that the panel has made. Choosing these to present has been important, but also challenging because we have more than we have time for. So just to help you understand why we chose these to present today, there were effectively three major criteria that went into that decision. First was the ranking in the prioritization process that was sought when we were first selecting questions, and that was a rigorous progress that Grigoris briefly explained that public and a whole bunch of other people had input into. Second piece of criteria was those we thought that would impact the largest number of people. And the third was around the feasibility of some of these interventions. So we tried to integrate those three factors to choose the ones to highlight today. So the first recommendation, it relates to exercise, and this is for adults with confirmed or suspected PCC. And it's really important to highlight there's a subgroup that has post-exertional malaise or post-exertional symptom exacerbation, because while some of the emerging evidence is suggesting that exercise-based interventions may benefit for a variety of reasons, there are some potential signals of harm or adverse effects, especially among people with PEM or PESE. So we sought to evaluate this more systematically and make a recommendation on it. Next slide, please. And so ultimately, the recommendation from the CAN-PCC collaborative is to suggest using exercise-based interventions for adults with confirmed or suspected PCC who do not experience PEM or PESE. So that's specifically in that group of people who don't experience that sequelae of PCC. This was a conditional recommendation that Grigoris just explained how that is to be thought about and implemented into practice. And the certainty of evidence for this was very low. Next slide, please. When it comes to people with PEM or PESE, the evidence was really insufficient to make a clear recommendation for or against its use. And so the committee made a recommendation that this should be done in the context of formal research settings only. And there are lots of different studies going on around the world that are beginning to look at this and recognize how important this subgroup of individuals are. So this is also a conditional recommendation with a very low certainty of evidence. Next slide, please. Just to give you an idea of the comprehensiveness of this evidence to decision framework that was developed by GRADE and how the evidence for these specific questions fit into that, there's a slide like this for each one of the recommendations today. And we don't have time to go through every domain. But first and foremost, we look at the benefits and harms in the center sort of pink box based on the literature. And we look at the balance. You know, clinical decisions are always a balance of benefits and harms. Then we look at other factors like the how people rate or value the outcomes and how those might be different across different groups. And we look at that at the level of the people with lived who are living with PCC, but also with the providers and also at the level of healthcare decision makers. Resources are the costs that are attributable to the intervention in and of itself. So not necessarily all the hospital space or clinic space you might need, but just the specific sessions for exercise in this case. We look at the cost effectiveness, if there are studies available, the acceptability across different patient, provider, and payer perspectives, the feasibility of doing this intervention. And then as Stacey talked about the Equity Oversight Committee, equity is always at the forefront of our thinking, and whether there are expected to be differential benefits or harms and other factors across equity-seeking groups, and whether there's evidence for that as well. So that will be for all of these. I'm just going to highlight and focus on the benefits and harms and the balance for the sake of time today for each recommendation. But as I mentioned, these will be available after. So with respect to the exercise intervention, we saw when you compare to no exercise, there are improvements in fatigue. So there's less fatigue reported among people who exercise compared to those who don't. They're able to walk further in a timed standardized test. There was some variation across their daily functioning and ability to sort of go on with their day. And overall, when we look at the magnitude, the size of these effects, the benefits were of moderate magnitude. Now, when we look at the harm, where we say, what are the harms associated with this intervention? There were actually less adverse events among people who were exercising compared to those who did not exercise. And overall, the size or the magnitude of the harms was considered small. And so the balance of those two with moderate and small benefits and harms is favoring exercise versus not. And the other factors are always very important, but ultimately at the end of the day, this is why this decision was really rooted in favoring exercise, with the important caveats around the PEM subgroups. Next slide, please. So this is the same table. That first one was just among people without PEM. Now we're looking at the same table among people with PEM, and this is where we ended up with the research recommendation. And ultimately, you can see in that balance bar, sort of in the center of the screen, while the benefits were still moderate, there were more concerns around harm in triggering PEM or PESE events. And so the balance between those two were both moderate magnitude, and the impact that PEM has on people's quality of life. And this is where our persons with lived experience on our team was really helpful to get and hear those stories. We ultimately recommended that this would be still in the context of research to really carefully address that in the future. Next slide, please. So the next recommendation looked at two different potential pharmacological treatments. So there was some really interesting results from a prior study looking at metformin that suggested possible benefit, and Paxlovid as one of the most common COVID antivirals to be used. And we were wondering whether this should be used among people who have established post-COVID condition, but at the time of a new COVID infection. So that's different than treating people with post-COVID condition to improve their post-COVID condition itself. It's more about a prevention strategy about worsening post-COVID condition or new symptoms that people with post-COVID condition didn't previously have. And the sort of the biological basis for this is that when you study metformin or these antivirals in the lab and in cell cultures of human tissues, we see that they reduce many of the mechanisms we believe are part of the contributing to the development of post-COVID condition and these symptoms around inflammation or persistent viral reservoirs. And the earlier you seem to give these medications within a time of a new infection, they seem to be more beneficial. So that suggests there's an antiviral mechanism and possibly in downstream anti-inflammatory effects to that. So that's sort of the rationale as to why this was an important question and how that's rooted. Next slide, please. Ultimately, this was a recommendation for the use of metformin and Paxlovid at the time of new infection, but we made a specific recommendation over the preferential use of metformin over Paxlovid, and I'll talk about that in a second. Next slide, please. Just to show you again that evidence to decision framework. Here, the benefits outweighed the harms. This is for metformin. You can see in that black box in the top left. There was a small magnitude of benefit on different outcomes and really trivial effects of metformin. Metformin's a well-tolerated, very low-risk medication. It's extremely cheap, so it's very feasible and it's widely available. So ultimately, metformin was felt to be beneficial in this case. Next slide, please. And so ultimately, how we made the decision to recommend metformin over Paxlovid is what you see here in this table, where we do a multiple intervention comparison. And you see on the left column there, the different domains from the evidence to decision framework, the two drugs that are being compared in the blue boxes across the top, metformin versus Paxlovid. And the more stars there are, the more favorable that domain is. So you can see, for example, in the first row, the balance of effects for metformin are actually the same on the balance of effects of Paxlovid when we went through those evidence to decision. However, the resources for metformin being a very cheap drug are far less than Paxlovid. So metformin gets 4 stars and Paxlovid only gets 1 because it's, several $1,000s for a course of Paxlovid. And so you can see the different domains there. And in the end, the bottom line is there's far more stars on the metformin side than there are in the Paxlovid side. And that is why metformin was ultimately felt to be recommended over Paxlovid. We did not have evidence and ability to make a recommendation about whether they should be used together versus not at all, or versus one versus the other. Next slide. This recommendation is a pharmacologic recommendation relating to a really common component of post-COVID condition known as cardiac dysautonomia. And POTS, or postural orthostatic tachycardia syndrome, is one of the more common dysautonomias that we see. And these have been known in the past, or thought in the past, to be triggered by other viral infections. And certainly I see a lot of patients with POTS and other dysautonomias related to their COVID infection as part of their post-COVID syndrome. And there are important ways to think about POTS and how to diagnose this, but a lot of people suffer with fatigue, palpitations, lightheadedness, headache, and nausea as a component or a characterization of their dysautonomia. Next slide, please. Ultimately, there are actually several different drugs, more than the ones listed here, that are used to treat dysautonomias, and a lot of it depends on whether people's heart is going too fast, or if it's the lightheadedness that's the problem, or some other symptoms that they can experience. But these are the most common, the ones that are most providers are the most comfortable with, and address the spectrum. They're sort of the first line, if you will, for each one of the different phenotypes of POTS. And so those drugs are ivabradine, which is it's a heart failure medication, but it acts on the sinus node to slow the heart rate down. Various beta blockers that do the same thing. Pyridostigmine and midodrine, those really act on the lightheadedness and raise blood pressure. And so we're looking at people with PCC and coexisting cardiac dysautonomia, where these drugs are really intended to help. And ultimately, we make a recommendation conditional for the use of these different drugs with very low certainty of evidence. Next slide, please. So this was the evidence to decision framework for all those comparisons of all those different medications. And so we see improvements in quality of life, both from a physical and social functioning, with moderate magnitude of benefit, and really small magnitude of harms. So the balance probably favors those medications over not using those medications. Now, it's important to recognize that because there's more than one drug, The costs can be quite variable depending on which drug you're using. Ivabridine's more expensive than beta blockers. It's a newer drug, as one example. And so, there are some variable effects on equity as well and acceptability across that. But ultimately, the sum total of the decision framework led the committee to recommend for their use. Next slide, please. One of the really common questions I get is about antiplatelets. And so there's a lot of concern, and we think that acute COVID itself is a procoagulopathic state, or a state that people are tendency to get blood clots. And there's lots of discussion about microclots in people with post-COVID conditions. So there was a natural question that was prioritized to look at whether, well, if you thin the blood with antiplatelets, for example, maybe that will help. And so that's why this was evaluated among our team. Next slide, please. But ultimately, the end result, we actually recommend conditionally against the use of antiplatelet therapies in adults with PCC, with an important caveat. If somebody has a pre-existing condition or indication for antiplatelet treatment, say a prior stroke or prior acute myocardial infarction as an example, or heart attack, you wouldn't stop the antiplatelet for those indications, but you just wouldn't add one if they weren't on those drugs for PCC specifically. And that was very low certainty in the evidence. Next slide, please. Here's the evidence to decision table for that. There's trivial benefits across a whole bunch of different types of outcomes, whether you're looking at death, venous clots, or arterial clots, but certainly increased risk of bleeding. So therefore, the balance of those benefits favored, the balance of those domains favored no antiplatelets, in addition to costs and equity impacts that these would have. Next slide, please. And our last one for today is to look at low-dose naltrexone, or really got a lot of press and a lot of interest from my patients. And just to help you understand, naltrexone itself is an analgesic agent. The low-dose formulation, so between 1.5 to 6 milligrams, is felt to have pain-relieving properties, but also properties around immunomodulation and stabilizing the autonomic nervous system. And if we look at some other conditions like ME/CFS, myalgic encephalomyelitis, and chronic fatigue syndrome, we see some potential benefits in the evidence there. Next slide, please. Ultimately, however, we made a suggestion against the use of low-dose naltrexone with very low certainty in the evidence on our conditional strength recommendation. Next slide, please. And just to help you understand how the team made this decision, so when we looked at the benefits and harms, they both came out as trivial. The drug didn't really seem to improve important outcomes, but it also didn't seem to cause any harms. When we look at the other contextual factors, however, this is where the concerns were raised by the committee, that the resources to formulate low-dose naltrexone is actually difficult and challenging. So there is no company that manufactures it in those doses. You have to find a specialized pharmacy to compound those doses for you. And in some provinces and territories, like the Yukon, for example, they don't have pharmacies that do that. So people were traveling to British Columbia to get low-dose naltrexone if they were interested in it. There are major concerns around the feasibility of that approach, and as well as equity, as you can imagine, about access to that drug and access to pharmacies that compound it. So ultimately, those factors really pushed the committee to recommend against its use. Next slide, please. And so I think this is about the end of our presentation. I really wanted to highlight that the CAN-PCC has an online recommendations map where we continue to update and add the recommendations as they are finalized through our process. Once a month, they are updated, and pretty soon we'll have all recommendations available to everyone. It's free. There's different ways you can navigate it, and I continue to look at it and direct my patients and my colleagues, clinicians, to it for their resource use as well. Next slide, please. There are also plain language recommendations that we develop so that it's much more accessible to the lay community and to people living with PCC and their caregivers. It's very simple. We spend a lot of time trying to get these right, and there's an enormous team in the background that does an incredible job of making these easily understandable in a simple and user-friendly way. Next slide, please. There's also different resources that are available, and so on the website, as you can see there, we have specific resources for patients. There's My Guide, there's interactive infographics and resource sheets, and webinars are made available. So really do encourage yourself and your patients to go access that. We also have separate resources for health professionals and other clinicians that you can see there. I won't go through those, but they are really useful tools, and I really encourage you to go through with them. So that's the time of our presentation. We have about 13 minutes left for questions, but I just wanted to thank you for your attention and time and for attending today. And I hope that it was a useful webinar for all of you. And again, thank you to the leadership of Holger and the team in leading this truly enormous but really important effort.
And Kieran, as you have seen, there were already a few questions in the chat that we started to answer. And Stacey, thanks for helping with that as well. Yeah, any questions? So for those of you who are so that in the chat we've answered questions, and then there are a number of questions that have been submitted through the Q&A section, right? So we can address them, but there's also a live question which Kieran and Grigoris and Stacey, I'm sure we are happy to take.
Absolutely, yeah. Go ahead. I think, is it Marjorie had her hand up?
That looks like Marjorie, yes.
Hi, thank you. I too am a COVID sufferer, I guess, if that's the right word, for about a year and a half now. I'm interested in the whole issue around how cost and accessibility fit into your recommendations. The question I put in the chat was if there are 2 million people suffering from a very low cost per person adds up. And why don't we look at these things in terms of per person's cost? Because if I'm sitting here saying, am I not worth $100? And if you multiply that by 2 million people, it adds up. So I'm interested in that, and I did get an answer, and I wouldn't mind pursuing that a bit more. In the case of the low dose naltrexone, if I'm pronouncing that properly, it strikes me that it might be useful to find a way of flagging it as a useful intervention, so that provincial governments, health systems, pharmaceutical companies, whomever, find a way of making it available. But to say that we're not recommending it because it is not currently available easily strikes me as foregoing something that could be useful.
Thank you, Marjorie. Those are two very important questions, and I really do appreciate them. I'll answer the second one, if that's okay, about low-dose naltrexone, and maybe either Grigoris or I can take a stab at it, just about the population perspective that we take about resources from a health economics standpoint. So with respect to the naltrexone, the decision is not exclusively made because of the lack of availability and feasibility, et cetera, to your point. But certainly those were very important factors. Ultimately, the evidence that we reviewed did not demonstrate any beneficial effects of naltrexone. So while it may work for some individuals, and that's why the recommendations are conditional, because you can't be certain it will work for you necessarily. But on average, when we look at the evidence tells us that on average, these drugs don't help. And so it's going to be very difficult to have provincial and territorial governments pay for a drug that has no beneficial effects and has other costs then associated with it, we need to know that a drug works before we make it available widely and pay for it at the policymakers level. So ultimately, that's why. And I'll just add that there is an ongoing trial in Canada, in British Columbia, that has been funded to actually study low-dose naltrexone in people with post-COVID condition. And we look forward to those results if they're able to successfully complete that trial, and hope that there might be an opportunity to update the guideline recommendations depending on the results of those trials. I hope that answers your naltrexone question. I don't know, Holger or Grigoris, if you wanted to address the population perspective on the economic and resource domain.
Yeah, I have quickly done that in the chat. I will be very brief if okay, in order to move to other questions. But essentially, what we had to decide is what type of perspective we are taking. And these are recommendations that are typically addressed from a population perspective. In other words, what might be cost for Canada, also to compare the interventions or to compare cost across different interventions, because resources are never unlimited. And so the way that the costs are presented is for typically for an annual basis for the whole of Canada. Of course, we could calculate cost per patient. That would be possible, but it would not be, in our view at least, as practical for decision making. And it's a relatively, let's say, well accepted approach for this type of guideline. Kieran, I wanted to make sure, I don't know if Grigoris wants to add to this, but I wanted to make sure, I know that one person has been waiting patiently for maybe Stacey to address one of the questions, and if that's okay, maybe we go there. It's Stacey, do you see the question?
Yeah, that would be great. Stacey's voice is so important, so please, Stacey, go ahead.
It's a message or comment from Steve Squires. He says, Stacey, I am a fellow Newfoundlander. I was hospitalized in July with an AKI under the care of an infectious disease specialist / internist. Over the 10 days in hospital, I presented with over 20 symptoms from brain fog, photosensitivity to the loss of the use of my legs. They were not able to diagnose me, telling every doctor I saw, all 16 of them, that I felt I had post-COVID condition. I was ignored, and the physician in hospital was hyper-focused on only wanting to address the AKI. All of the testing came back normal. When released from hospital, I had to call all internists in my area. I was eventually put in touch with the right physician who is part of your cohort that was able to immediately diagnose me based on the exhaustive testing and their results. How do we address educating our physicians, especially in Newfoundland and Labrador, where the population is lower and certainly do not have a dedicated clinic for patients with post-COVID condition? First of all, I'm sorry for your experience. That sounds very not only traumatizing, but exhausting, because it's hard to get that message out. And I'm really thankful that our guidelines have that good practice statement about validating your patient's concerns. And I know that is a good practice statement, and it should be amongst all practitioners in all different areas, but specifically with long COVID and post-COVID condition being so new, it's important that that's also ruled out. I'm guessing, and you might be able to let me know, are you talking about Dr. Anise? Were you referred to Dr. Anise? I don't know if he can answer in the chat there, but
yes.
Okay, yeah. Speaking of validation, this is something that I shared with the guideline team in my process. I was sick for over 2 years before I got to see Dr. Anise. And when I walked into her clinic, she had over 30 pages of my medical tests from the last 2 years. She had read every single one of them. She wanted to discuss what she picked up on. And I had a stack of like research articles in my hand and we talked about it and I just started to cry. And that's the value of feeling heard and having your healthcare practitioner believe your symptoms and let you know that you're not alone. So I'm really thankful that you were also referred to her. Speaking about education, these guidelines will be these webinars and some other initiatives from CAN-PCC are used to educate people and physicians. But I did want to let you know specifically that Dr. Anise is doing education sessions with doctors throughout NL Health Services. I was speaking to her recently about that, and she has recently teamed up with Long COVID Web. So Long COVID Web is also another initiative in Canada that helps long COVID patients and people within research addressing and clinicians and everybody to get together, talk about what is the most current research, what is being recommended. And I know the guidelines will likely be addressed at Long COVID Web, which is having a symposium, the 3rd annual symposium in St. John's, Newfoundland and Labrador next October. And Dr. Anise and Dr. Hall, who also is he's wonderful. He's in the St. John's area, if you're there. He's helped me out greatly. And I say like my doctor's appointments are like a nice conversation. So, we talk about stuff. We go over my results and things too, but it's really nice. It's 2 very wonderful people who are taking this on. And hopefully I can actually post the link in the web for Long COVID Symposium. And it will be shared within NL Health Services. So hopefully we can get that to the physicians, family practitioners, and the family care teams that are located across the province, specifically in areas where there's a shortage of family doctors.
Great. Thank you, Stacey. So there's Grigoris. I don't know if you want to take that next question, or Kieran. There is a question in the chat. I expected more data on what is working for patients and what isn't, without the complication of understanding the recommendations. Are you seeing favorable results with one treatment over another?
Yeah, I could say that. I mean, of course, we didn't have time to explain, to describe all the evidence now, but when this guideline is published in full, we will have all the evidence to decision frameworks and the evidence profiles with very detailed description of the evidence. So you will be soon be able to actually see all the evidence and step by step. And if you need to ask anything, you can always submit questions. Thank you.
Yeah, and it's perhaps also a good good reminder that, as Grigoris just emphasized, that the actual data are available, but we're not the focus necessarily of the presentation today, right? Just to reiterate that. So the data that support recommendations, albeit they are sparse in many instances, are available to review in detail as well. For those recommendations that are finalized, you can review them on the website that is on the next page. So there's detailed information for all of the recommendations as they are published available. And so please visit us online, both in French and in English, of course. Other questions were already answered, but I think we have to draw it to a close at this point with some final remarks. And then I will also ask, of course, the panel to comment on that. So 2 additional webinars, one on prevention of post-COVID condition, then for neurologic and psychiatric topics, and then we also have pediatrics. I think that maybe on the next slide, coming up in the future. March, I think it is March 27th. Heather put that in the chat. And of course, here's our QR code. We also have a newsletter. And to the panelists, there's a question about ketamine. We can probably go maybe a minute or 2 minutes over, and how the guidelines are being shared with ER physicians. So we really try to do as much dissemination and information as possible. Let me check quickly in with our panelists if there's anything to add, or if you can take a quick step at the questions before we break.
Happy to. I just can't find the question on ketamine. Maybe you could read it for me.
Oh, of course, yeah. I would like to know if anyone has any experience with treating PCC with ketamine, given the anti-inflammatory properties. And there was another question. It might have been from Steve Curris here.
Yeah, thank you for that question. As far as I'm aware, there hasn't been any published literature looking at ketamine. That isn't to say that it's not necessarily out there, but that ketamine wasn't one of the interventions that was prioritized in our prioritization process. Anecdotally, I use ketamine in my practice as a palliative care physician. It has interesting properties around modulating pain pathways and other neuropsychiatric effects. But the short answer to your question is I'm not aware of any evidence, whether it works or not, ketamine for the treatment of PCC.
Any other final remarks before we end? From Grigoris or Stacey?
Just thank you, everyone.
Oh, I guess I should mention it. I meant to mention it when I responded to Steve. And I saw Marjorie possibly or potentially had a question earlier regarding the how do we educate, people like in the ER, et cetera, in terms of using the guidelines. My reinfection in summer 2020, I can't remember which reinfection it was. I try really hard not to get infected as well, and it still happens to the best of us. But my last reinfection, I brought the guidelines specifically to a doctor because my doctor was on leave, and it was someone who was not familiar with my case, but they went through my chart and they went through the guidelines with me, talked it out, and they were comfortable prescribing what was recommended based on my history and the guidelines. So don't be afraid to take the guidelines to your physicians.
Absolutely. No, thanks, Stacey. That's a good remark and a good end to our webinar today. Thank you, everybody. Thanks to the panelists and to everybody who joined today for the questions and of course for the participation in general.